Okay, today we're going to do idiopathic neuropathy. It's time to have a glucose tolerance test. And this is an extremely important topic. There is such a huge misunderstanding out there about idiopathic peripheral neuropathy. We might even make the argument that idiopathic peripheral neuropathy doesn't exist. In fact, I'm pretty sure we're going to make that argument. We're going to talk about that. We're going to talk about why people tell you that 50% of it's diabetes and 50% of it means I don't know what it is, idiopathic. The other term can be used as cryptogenic. We're going to talk about our observations. Dr. Gates and I work in a chronic, we have inadvertently developed a chronic pain clinic by putting together Dr. Gates' discipline. Dr. Gates is?
Board certified chiropractic neurologist, also a chiropractor.
And I am a certified functional medicine practitioner and a chiropractor. So technically, say we put those three disciplines together. So in doing so, we have developed an logarithm for addressing chronic pain, and peripheral neuropathy may be the largest group of patients that we see of all the chronic pain patients that we have. We're going to talk about never accepting. Just as I said before, we're going to talk about never accepting a diagnosis of idiopathic. You should demand. We're going to talk about why you should demand that your doctors look further for what the cause is, or refer you to somebody who's willing to do that. We're going to talk about the glucose tolerance test, which in my mind has been a test that has been kind of long forgotten. And this is so important to you. This is so important. So you better stay tuned until at least we say that. And why this glucose tolerance test is maybe going to become the gold standard for figuring out various types of blood sugar related peripheral neuropathies. And then once you have this data, we'll tell you what you can do with it. So peripheral neuropathy. Peripheral neuropathy, most patients come in here to me. I do the intakes. Dr. Gates and I do the exams together. Dr. Gates does pretty much all the treatment. So in the intakes, I'm listening for, okay, you have peripheral neuropathy. So I start listening for all the different reasons that we're going to talk about. We are not going to talk about all of them. But the fact that there are a lot of different things that cause peripheral neuropathy. There are a lot of different causes, okay? And so I start listening to those. And what I hear frequently is, when I went to the doctor and he told me 50% of peripheral neuropathy is diabetic and the other 50% we don't have an answer for. Well, as I'm doing the consult, I understand that's not true. So I start asking questions, start teasing out what are your symptoms, when do you feel them, because specific symptoms can lead you to specific initial diagnoses. So why don't I turn it over to you from here?
Okay.
And because we'll have you get more into the specifics of 50% of people have diabetes, the other 50% we don't have an answer for, why that's incorrect and why that's probably going to lead to having patients never accept the fact that there is a diagnosis given to them of idiopathic peripheral neuropathy.
In essence, the answer to the question as to why so many of you have been told that you have idiopathic peripheral neuropathy is because the insurance industry is squeezing your doctors. That's just the fact of the matter. Why don't we just shoot straight? Sometimes we try to beat around the bush because we're trying not to step on toes or hurt feelings. But in this situation, we kind of have to call a spade. And in 2014, Journal of the American Medical Association, Neurology Division, came out with an article on peripheral neuropathy, and they looked at 9 different neurologists, I believe in Texas, and how they were diagnosing and evaluating different peripheral neuropathy cases. And what they determined was that most of the testing run by these neurologists was fruitless, meaning it didn't yield any improvements, so to speak, for the patients. It didn't alter outcomes because in essence, most of these patients with peripheral neuropathy were going to end up on gabapentin, Lyrica, drugs of that nature, possibly tramadol. And so they were going to have to just take those medications. And because of this, the insurance industry, the authors from the study I'm not going to say who they work for, but you get where I'm going with this. And the authors said that in essence, neurologists should only be allowed to check for diabetes, hypothyroidism, and B12 deficiencies in peripheral neuropathy patients. And they shouldn't even be allowed to order an MRI of the neck or the lower back to differentially diagnose whether someone actually had like a bulged disc in their neck hitting the spinal cord, or a bulged disc in their lower back hitting nerves coming out of the lower back. Hence, this is an illustration of what's been happening to your neurologist through the years. And while some neurologists still are able to order a battery of tests because your insurance company will allow them to, more and more insurance companies are going to this model of limiting your doctor on what they can test you for. Therefore, your doctor doesn't necessarily want to say that. So they're going to say, Joe, you have idiopathic peripheral neuropathy. You don't have diabetes, or but you have nothing that we know that can help you. We'll talk about that as well. And you're going to take XYZ, ABC medications for this problem. Come back and see me in 3 months and we'll go over how you're doing.
And why are you saying that only allowing them to look for those 3 things is limiting?
Exactly. So it's limiting because there are 80 different causes at least of idiopathic peripheral neuropathy. And idiopathic peripheral neuropathy is one of the most exciting diagnostic adventures a doctor can go down in figuring out why you have dying and degenerating nerves in your feet, maybe spreading up to your knees and involving your hands. There are.
And who says there are 80 different causes?
The reference for that is the Contemporary Neurology series, one of the most highly regarded neurological textbooks and series of textbooks that's put out. And that comes from a textbook on peripheral nerve disorders that we have and we frequently have referenced.
Put out by the medical profession.
I think its technical title is Peripheral Neuropathies in Clinical Practice. So there are scores of different causes of idiopathic peripheral neuropathy, ranging from autoimmune disorders to infectious processes to vitamin deficiencies that we know all of you are aware of, which actually affect a very small percentage of you, to things like celiac disease, to food intolerances, to gastrointestinal conditions, to hepatitis, to renal failure, that's your kidneys.
And it's all in the medical book. Stand for peripheral neuropathy in the medical field.
Right. And I can go on and on. Genetic conditions, bone marrow problems. There are a lot of different causes for the idiopathic peripheral neuropathy sufferer. And the world's foremost researcher on peripheral neuropathy from the Mayo Clinic says that in you idiopathic sufferers, you should be able to figure out the cause 76% of the time. We're going to argue here that with this new data regarding the glucose tolerance test, possibly the percentage is much higher of you with idiopathic peripheral neuropathy should be able to figure out the cause of your symptoms. And that cause can be figured out if you have a detailed history, a detailed examination. Some of you may need electrophysiologic testing like EMG and nerve conduction velocity testing, sometimes not. And you need all those pieces put together with appropriate lab testing directed at the problem based on the history exam and possibly the EMG and MCV findings. And then with that, you can figure out a person's peripheral neuropathy when you're not handcuffed by what a third-party payer is telling you to do.
And even within the insurance companies allowing that person to look for blood sugar problems, B12 deficiencies, and thyroid, there's still a tremendous amount of misdiagnosis in that realm,
absolutely,
particularly in
this
blood
case.
sugar.
Yeah, we should do a topic
area.
just on that. That would be great.
Yeah.
We really should. But
okay,
relative,
we'll do that separately because that's right now. But we'll do that.
We can tie it in if you want to.
No.
Okay, so we'll go separate with that.
We'll do what we planned.
Okay, so relative to this whole topic, this is fascinating because this is relatively new. Many of your neurologists were trained before this information came out. So you just have to give them a little credit. You have to give them a break. They've been seeing the world through a certain vantage point. And some neurologists, I say this because some of them don't, quote unquote, believe that prediabetes can cause peripheral neuropathy. Whereas the data is frankly overwhelming. We would beg to differ with anyone on this.
Yeah, I guess technically those codes don't allow you to look for prediabetes and treat it.
That's also true.
Technically.
You know, I've talked to medical
We're going
doctors.
to tell you how important prediabetes is to you who have small fiber neuropathy, burning numbness, tingling, sharp shooting pain in your feet.
And it's very interesting. There's a lot of stigma associated with this. So I've talked to certain neurologists where they'll say, yeah, you know, I just don't even want to treat pre-diabetic peripheral neuropathy patients like with a blood sugar medication because my colleagues will feel that I'm kind of a quack, or I'm outside the limits. These are the thoughts going through their head, when in actuality, the data is there now that the pre-diabetic peripheral neuropathy patient needs to be treated. But also you have to realize that the standard lab tests used to diagnose this are missing the problem in a huge percentage of pre-diabetic, insulin-resistant, impaired glucose tolerance patients with peripheral neuropathy. So that's the story. So I'm going to go at the study. So the study came out in 2001. Diabetes Care, it'll be attached to today's broadcast. It was by 3 people, but 2 of the main authors are from the University of Utah Medical Center. They have a huge neurological division with focus on peripheral nerve disorders. These 2 guys, Dr. Smith and Dr. Singleton, came out and they looked at how when people present with diabetes, so these are patients not complaining of neuropathy, just diabetes, 10% of them have signs of peripheral neuropathy. So from this, they inferred that the diabetes, though has not caused a horrible peripheral neuropathy yet, where the person's agonizing with horrible pain in their feet or they're totally numb in their feet, the accumulation of blood sugar being elevated over time was enough to damage their nerves. So they begged the question. They said, well, we have this huge group of idiopathic peripheral neuropathy patients. What if some of them have just subtle blood sugar dysregulation? Maybe they're pre-diabetic. Maybe they have syndrome X or metabolic syndrome. Some of you may know that means you have pre-diabetes, you have high cholesterol, your blood is coagulating too easily, your waistline is too big, so on and so forth. So they took 107 idiopathic, and I'm always using quotation marks around that, idiopathic peripheral neuropathy patients. And these patients had tons of testing before this study was completed. They've been tested for diabetes. They had been tested for pre-diabetes. They've been tested for a variety of different problems. And with these 107 patients, they found that 13 actually had diabetes, full-blown diabetes, when performing the glucose tolerance test, and 36 had pre-diabetes when performing the glucose tolerance test. Pause there. So you're probably wondering, okay, well, what is a glucose tolerance test? That's the title of today's broadcast. The glucose tolerance test is where you drink, in essence, 75 grams of glucose, so about equivalent to a can and a half of your favorite Coca-Cola or Pepsi. And you drink that sugar all at once after you have a baseline blood sugar read, and then they start taking your blood sugar every 30 minutes to an hour. Typically, it's every 30 minutes after that. And by the 2-hour mark, if you're normal, your blood sugar should be below 140. If you're pre-diabetic, and I'm saying this within that 2-hour time span. If you're normal, your blood sugar really shouldn't go above 140. If you're pre-diabetic, you're going to go between 140 and 200. And if you're diabetic, you're going to go above 200. So it's a great way to examine how your body is processing insulin, how the insulin is processing sugar. As Dr. Rutherford said, he did this test when he was going through school, and it made him massively sick. It's a miserable test. They do this on pregnant females. Most females know that this is a horrible test. You were going to say something before we go on.
So the salient point is many people come in here who've been told that they have peripheral neuropathy, but it has nothing to do with their blood sugar. And they're being told that in some offices because they don't have diabetes. Right. They're being told that in a lot of offices because they've been shown to have pre-diabetes, which does cause peripheral neuropathy, but the testing is still not saying that they have pre-diabetes. So that doctor, even if you have the pre-diabetes, they might not think to test you, or if they were a doctor who is one of the numbers of doctors who is starting to understand that pre-diabetes is a problem, and your testing wasn't showing that you have pre-diabetes, but you have all the symptoms, they wouldn't treat you. But if they did this test might show that you have the pre-diabetes when all the other tests that you've had right now haven't.
Right, exactly.
So this test needs to be done to complete the understanding, the true understanding of your blood sugar picture.
Absolutely.
And then ultimately the doctor has to embrace the fact that pre-diabetes causes peripheral neuropathy.
True.
So listen to the rest of this with that in mind.
Exactly. So just going back through it, you drink the 75 grams of glucose, your sugar should be below 140 for those 2 hours. If you're pre-diabetic, you're 140 to 200 or 140 to 199. If you're 200 and above, you're diabetic. And in this study, they found that 36 people were in this 140 to 200 range, which is astounding. And this is an illustration. What happens when you eat a mud pie? What happens when you're out and you have a plate of pasta and you have a few drinks and then you're having dessert? Well, that's basically equivalent to this glucose tolerance test. So when you're doing that, your sugar is elevating above what it should be. That's the whole point. And when it goes this high, there are 3 tissues in the body that are selectively damaged by high blood sugar. The eyes, the retina specifically, nerve tissue and the brain and the peripheral nerves, as well as the kidneys. And so especially in this context, when sugar just elevates above what it should be, but it's not horribly elevated, what it does is it attracts water primarily into the small nerves down there in your feet and your legs, causes them to swell, and it's associated most commonly with burning, tingling symptoms, particularly with a time correlation to the evenings. So those of you who say, man, my feet just burn at night, or I have to kick the covers off because my feet are bothered by the covers, or my feet feel really hot at night, these are the patients that they started looking at in this original study in 2001. As Dr. Rutherford was saying, these patients had had normal blood tests. They had a metabolic panel where their doctor looked at their glucose the day or the morning where they were fasting. These patients actually had 3-month measures of blood sugar, to my knowledge.
Right.
And they had looked and they didn't have prediabetes based on that. But when they did this glucose tolerance test, they saw an astounding elevation in these patients, where 36 of them have prediabetes. I think probably the more frightening figure was that 13 actually had diabetes and no one had picked up on it through
and
normal labs.
In the old days, and it all comes down to diagnosis. I mean, I'm 63 years old. I was taught in the mid to early to late 70s. And back then, if a person came in and they had all the symptoms of some sickness, but the testing showed they were normal, you would go ahead and treat for that because nobody else had an answer, and you were considered a good doctor at that point because usually they were going to care. But today, you have people walking in, they got burning, they got sharp shooting pains, they're kicking off the covers at night. These are all classic signs of small fiber diabetes, and these people are being told it's idiopathic.
Right.
They're being told, we don't know what's wrong with it because the test says you're normal. That study shows they were told that their blood sugar was normal until they did the glucose tolerance test. And even that's going to miss some. Even that will miss some. Even symptoms will frequently come sometimes shortly, long before there is testing that's going to confirm something. In today's litigious society, another thing your doctors are thinking about, nobody wants to get sued by treating for something that they don't have a solid test for. So this gives one more tool that widens that range of the ability for the doctor who wants to look for those other causes instead of saying you got idiopathic, to be able to make that diagnosis.
Absolutely. Absolutely. That's a great point. Because a lot of doctors are afraid to treat patients with blood sugar disorders according to what we now know will help neuropathy patients.
Yep.
So there's this diabetes control and care and intervention study. I can't remember the title. It was something of that effect. It's in our book, where they took 1,334 diabetic patients and they tightly controlled their blood sugar. So they kept it, just for those of you who don't know this, for a diabetic patient, the 3-month measure of blood sugar, doctors feel it's good control if they keep that 3-month measure of blood sugar at 7%. It's called the hemoglobin A1C. Just know that below 5.6 is normal. But in the study that I'm referencing, where they took 1,334 diabetic patients, they got it below 7 and they tightly controlled their blood sugar. Even after 10 years, they were much less likely to ever develop peripheral neuropathy. Those who did develop peripheral neuropathy, the neuropathy was less severe. It was a fantastic improvement, but I think 1 or 2 patients had negative consequences. So because of that, doctors don't really want to control your blood sugar that tightly because they're putting themselves at risk. And especially to walk into this pre-diabetic range, they're putting themselves more at risk. So that's kind of the layout of it. So the point being is that now if we take idiopathic peripheral neuropathy, and so if we have a pie, 50% is diabetes, the other 50% is, quote, idiopathic. Now we have at least 33, some estimates upwards 40% of the remaining 50% is associated with impaired glucose tolerance because this was the proper test to be run. And as we were discussing before this broadcast, this is a test that's taught to everyone all physicians learning diagnosis
I got
as a
it
gold
back
standard
I got it back in the 70s.
for diagnosing blood sugar regulation disorders, but it's not commonly employed, probably because it's a miserable test because you feel kind of sick afterwards. And also, it's just not within the paradigm anymore of textbook or cookbook, so to speak, diagnosis. So the cookbook diagnosis is you run a metabolic panel. Maybe you run a hemoglobin A1C, which is a 3-month measure of blood sugar. And just so you know, a lot of insurance companies don't even want to pay for that test. And so you're told either you're normal or you're abnormal. And that's why a huge blind spot is there for these impaired glucose tolerance patients. Now, this raises the question of, well, if you actually run the right tests, as we discussed earlier, we're finding that a big percentage of idiopathic peripheral neuropathy patients can have a cause determined. So if you're not handcuffed, so to speak, you can run the other tests to figure out if they do have celiac disease, do they have a gluten intolerance, what type of vitamin deficiency does this person have, do they have a family history of peripheral neuropathy, do they have another GI disorder, malabsorption problem to their peripheral neuropathy, do they have autoimmune disease, do they have a bone marrow problem? All these things need to be ferreted out really after you do the history and the examination to then kind of whittle it down as to what this neuropathy looks like. Because we'll tell you, from the examination perspective, an alcoholic patient who's well nourished will have a completely different clinical examination finding and presentation than an alcoholic who's not well nourished. So there are stark differences there, and when you're astute in these types of things, you can figure it out. So what else did you want to add in there, Doc?
No, I think you pretty much covered it. I just thought, as you're speaking, and this is on peripheral neuropathy, but I just think of the things that are not covered. And I just think, for example, post-cancer peripheral neuropathy is not covered, to be treated under the insurance code. So it's just how they came up with these, I have no idea. But really, the takeaway is you shouldn't accept the diagnosis of I don't know. You should question. You should not be insulted or upset. If your doctor gets insulted or upset, realize they're probably just frustrated, and you should look elsewhere. And what can they do? What can they do? What can they do when they get a diagnosis of idiopathic diagnosis?
So it's recommended by,
in addition to what I just got done saying,
Dr. Smith and Singleton, is for these patients to start exercising, for them to change their diets, and they saw some improvements with doing this. In our experience, because these patients we're talking about with impaired glucose tolerance frequently have small fiber neuropathy manifestations. These are patients with burning foot pain, and lots of times they have a hard time exercising. They have a hard time walking. They have a hard time getting from our front office to our back office. So exercise is not necessarily the most feasible solution. A lot of people have a lot of confusion about diet and what the appropriate diet is. A lot of people have trouble sticking to a diet, hence why 2/3 of our population has a weight problem. So that's not an easy solution either. So that's what's recommended. They also discuss blood sugar medications for these patients, but again, a lot of doctors feel like they're walking out on a limb with this. And another point I want to make is that since 2001, Dr. Smith and Singleton have pioneered and done a lot of research to basically show time and time again that impaired glucose tolerance causes peripheral neuropathy. It has been substantiated at other places like Johns Hopkins University by Dr. Sumner. It's been substantiated at the Cleveland Clinic. Pretty much everybody is on board with this, aside from one little small research group. But the data is overwhelming that this is a problem. It's causing a huge percentage of idiopathic peripheral neuropathy cases. And you, as the idiopathic peripheral neuropathy sufferer, if you're watching this and you haven't had this test done, it may be a good idea to have this test done. We're not diagnosing you, but we're just trying to lead you with more information.
Yeah, especially if you have burning, numbness, tingling, sharp shooting pain, you should have this test done.
Yeah.
If they're telling you what it is, you should have this test done.
So that's today's topic. Now, if you have more questions, if you want more information on diabetes to other forms of neuropathy, go to powerhealthtalk.com. Go to the search tab, search peripheral neuropathy. You'll see lots of videos pop up. Everything we talk about is peer-reviewed and referenced, so we'll attach articles to it. We'll have that key article that we talked about today attached to today's broadcast. And we really appreciate you watching, and we'll see you next week.